This week we are covering Chapter 7 in your textbook, which is on anxiolytics and sedative hypnotics. Anxiety disorders are the most common psychiatric conditions. The book gives the figure at 28.8% for the lifetime prevalence, which is huge. And then there's various anxiety disorders that we're going to go through here. PTSD and OCD are now in the DSM-5 actually categorized differently. OCD is its own category, and PTSD is categorized with disorders triggered by outside events. But we're still going to discuss them here just because they're included in the book and also because they're often treated similarly. So a generalized anxiety disorder, a person's just nervous, always on edge, it's difficult to concentrate, they can't perform their daily tasks, they're worrying about all kinds of stuff, it's generalized. And neurophysiologically, what we see here is increased activity in amygdala. Remember, that's the center for fear in the brain. And an underactive ventromedial prefrontal cortex, which suppresses the amygdala. So you've got a more active fear center and an underactive part of the brain that's supposed to keep that fear center in check. So you don't need to memorize the parts of the brain that are affected by each different disorder, but that's how people just have generalized increased anxiety in this disorder. Social phobia or social anxiety disorder is the most common anxiety disorder. People are not afraid of other people, but afraid of being rejected or embarrassed in social situations. So social interactions are distressing because a person's just constantly worried about their behavior and what others think of their behavior. And again, here people show a more active amygdala, orbitofrontal cortex, and again, don't worry about memorizing the parts of the brain. Then specific phobia, there's different categories of specific phobias, but people are afraid of spiders or dogs or snakes, heights or flying, some kind of specific phobia like that. And again, it's not just that I think dogs might bite me, so when I'm out for a run I cross to the other side of the street. It's like an overwhelming, irrational fear of whatever the phobia may be. This shows heightened activity in a bunch of different parts of your brain listed in the book. It talks about the visual areas of your brain, the supplementary motor region, thalamus, amygdala, anterior cingulate cortex, and insular cortex. Then panic disorders are panic attacks. People experience panic attacks that are unpredictable. So it's not a specific phobia or trigger for the attack. It's not like the phobia of spiders that we just talked about, but rather this just comes out of nowhere. A person's sympathetic nervous system just goes into full-blown fight or flight response that we've mentioned earlier. And if someone's unfamiliar with what a panic attack feels like, they might think it's a heart attack. They've got chest pain and racing heartbeat, things like this. And then specifically panic attack with agoraphobia means that a person is afraid to be out in public because of their panic attacks. They won't be able to escape or get help for their panic attacks if they have one. Parts of the brain affected here, they've got a decreased anterior cingulate cortex and increased gray matter in various parts of the brain. And so now the two disorders that have been recategorized, but we're still going to discuss here. First is OCD, obsessive compulsive disorder. So you've got both obsessions and compulsions with this disorder. An obsession is a thought that a person can't get out of their mind. Maybe they feel like they're not in control or something horrible is going to happen. And then the compulsion is the repetitive behavior that they engage in, trying to relieve or get rid of that obsession. So washing hands or cleaning in an extreme way, not in a healthy way, like before you eat or when you come in from outside, but repetitively and extreme way or frequency could be a compulsion because of an obsession over germs or infections or something like that. People suffering from OCD have a decreased volume of hippocampus and amygdala, larger anterior cingulate cortex, deformed thalamus, less active areas and more active areas of the brain. And the point here is just that there's a lot of different areas of the brain involved with this disorder. And then final one we're going to talk about is PTSD, post-traumatic stress disorder. And here, a traumatic event causes this feeling of constantly being on edge, watching for danger, feelings of detachment from themselves and loved ones. And that traumatic event, we've all heard of this happening after combat, soldiers returning from combat, but it can also be due or be the trauma that then results in post-traumatic stress. That trauma could be abuse or assault or an accident or a lot of different things. And here people have a smaller hippocampus, anterior cingulate cortex, insula, as well as dysfunction of the amygdala and prefrontal cortex. Comorbidities for anxiety disorders include depression and insomnia. Comorbidities, it just means a lot of times people have these at the same time. So an interesting point is that people with depression as well as people with anxiety disorders have an increased likelihood of short alleles of the serotonin transporter promoter. So this regulates the number of serotonin transporter proteins, and serotonin itself regulates mood, appetite, sleep. So it's not so surprising that effects of serotonin transport could influence things like mood and sleep. And in fact, there's several antidepressants that modulate serotonin, MAOIs and TCAs and SSRIs. Again, you don't need to know those specific classes of drugs, but and then anxiety disorders also coincide with insomnia, and many of the same drugs to treat anxiety disorders can also be used to treat insomnia. So just to define the terms that we're going to use here, there's somewhat of an overlap in terms. Anxiolytic means that it cuts anxiety, literally. Lytic means it cuts anxiety, anxiolytic. So it's an anti-anxiety drug. This term is applied to drugs that are used therapeutically to treat agitation or anxiety. A sedative is generally considered as something that's calming, it sedates, and it reduces anxiety. And then a hypnotic refers to drugs used to aid in sleep. So when the book talks about sedative hypnotics as one lump, they're talking about drugs used to aid in sleep in that case, but used separately. You can Google it. Sedatives are calming or sedating. They reduce anxiety. And then hypnotics alone, that term refers to drugs used to aid in sleep. So I know that's confusing, and I'm not sure why the book lumps together sedative hypnotics separately from anxiolytics. But there you have it. Anxiolytic is anti-anxiety, sedative is calming or reducing anxiety, and hypnotic is drugs helping to sleep. So then if you lump together sedative hypnotic, it'd be something that calms and helps you sleep. Okay. There's a bunch of different drugs that the book introduces us to. Barbiturates were used a lot in the early parts of the 1900s, say until the 1950s. They replaced alcohol and opiates and things like that to help with anxiety and insomnia. A lot of these have been marketed. You can see table 7-1 for a list of some of them. And they're downers on the street. And then the benzodiazepines replace barbiturates effectively. The barbiturates are still around. They're still prescribed at some level, but benzodiazepines were starting to be developed in the 50s and 60s, and these just have better therapeutic indices. They're safer to use, and some of the well-known benzodiazepines include Valium, Xanax, and Roofies as well. Then non-benzodiazepines are drugs that have been developed more recently than the benzodiazepines. There's several specific examples here: abercarnal, alpidin, and the Z drugs, zolpidem, zopiclone, and zalopon. These have a shorter duration of action, so then there's less risk of tolerance and abuse that comes with these drugs compared to the benzodiazepines. All of these drugs modulate GABA A receptors, which we'll talk about in depth soon in the neurophysiology section. And then the other drugs the book mentions to treat anxiety and to help people sleep include over-the-counter sleep aids, antihistamines, melatonin, antipsychotics, and antidepressants, which we mentioned on the last slide as well. So barbiturates and benzodiazepines affect the GABA A receptor. They modify transmission of GABA, which is the primary inhibitory transmitter in our nervous systems. So you recall this figure from last week with our discussion on alcohol. This is figure 7-1. It's the GABA A chloride ionophore complex. So the GABA A receptor is a chloride channel, and when GABA binds, it allows chloride to flow into the cell, or into the membrane, into the cell, across the membrane, which hyperpolarizes the membrane, making it harder to fire an action potential. That's why GABA is an inhibitory neurotransmitter. So one withdrawal symptom from these drugs can be seizures, because GABA, as an inhibitory neurotransmitter, prevents excess excitation in the brain. It prevents seizures, which can result from too much activity in the brain, which is why when you stop taking these drugs, if you go cold turkey, you can cause, the opponent processes, the B processes in your body can cause excess excitation in the brain, too much activity in the brain, and therefore seizures. So recall from last week that there's many permutations possible with this receptor. There's different subunits and even different subtypes of those subunits. The one shown here is the most common configuration. It accounts for about 60% of the receptors. And then we're going to step through this just showing each binding site. So two GABAs can bind. Those are labeled GABA. When they bind, the chloride ion channel opens and lets chloride flow in, hyperpolarizing the cell. GABA, benzodiazepines, and barbiturates all bind different sites, allosteric sites, so they modulate the effect of GABA binding. They each have different affinities and different sites, so they can, first of all, they're not competing with each other. Second, they can have additive effects. And third, the book talks about different affinities and different sites. They have, depending on their binding affinity, they can alter the effect of GABA up to 700%. They can make GABA neurotransmission up to 7 times more effective. And then another point here is that different drugs have different effects on the subtypes. So the book talks about specific effects on alpha 1, alpha 2, and so on and so forth, for example. And then the last point here is endogenous substances, which is one theory to explain why these drugs have their own binding sites, why these allosteric sites exist. It's theorized that these endogenous substances, endogenous just means that it's already inside of us, these endogenous substances help us deal with stress and distress. They modulate the effects of stress. It's possible that they also work as inverse agonists rather than as agonists, and if you need a refresher on that, go back to the agonist spectrum PDF in chapter 4 that we talked about several weeks ago. These drugs are typically administered orally or parenterally by injection. They're weak acids, so they're readily absorbed. Oral administration is a little bit slower to be absorbed, but it allows for a longer acting effect. And then injection gives a more immediate effect. Intravenous injection gives a more immediate effect, but it's also shorter acting. So typically people on prescriptions for anxiety would be prescribed oral medication. And then injection would be used, say in the hospital, if someone is agitated or they're afraid they're going to hurt themselves, something like that, they would be injected so it starts working right away and they'd calm down more quickly. Absorption from the digestive system can be significantly increased by co-administration of alcohol. This can be a really dangerous combination. Again, remember ethanol and barbiturates and benzodiazepines all have separate binding sites on the same receptor, the GABA A receptor that we were just looking at in the last slide. So their effects can be additive, and that's why it's so dangerous to combine those drugs. The distribution and duration of action of these drugs is affected quite a bit by their lipid solubility. Highly lipid soluble drugs tend to be quick acting. They get to they can exert their effects very quickly. They're also quicker to be metabolized and excreted. They're also more easily stored in fat, where they can be released over time from the fat. So they give a two-phase curve. The first phase, their half-life is 2 to 10 hours, again, depending on the drug and depending on the individual. And then in the second phase, as the drug in the blood is much slower to drop because of the slow release of the drug from the body fat. And the half-life in this phase is on the order of days. The book says 27 to 48 hours. But again, there's a big variability between individuals and for different drugs. Another issue with these drugs' duration of action is that the metabolites are sometimes active. So for some drugs, these active metabolites could have a similar effect as the drugs, or it could be somewhat different as well. This tends to happen with the older benzodiazepines, things like Valium. The newer versions, like Xanax and Klonopin, they don't have active metabolites, and that's intentional. The drug developers have paid attention to that problem, so now the metabolites tend to not be active. These drugs can cross the blood-brain barrier as well as the placental barrier, so obviously keep that in mind if you're dealing with pregnant mothers. And then the metabolism of these drugs is slowed, and so the effects are prolonged by alcohol. Barbiturates depress respiration and slightly decrease blood pressure. Outside the central nervous system, the benzodiazepines have very few effects. They may be used for muscle relaxants, anticonvulsants, and to increase appetite. And so some side effects include those properties, such as weight gain with increased appetite, things like that. And then their sleep aid, another popular use for them is as sleep aids. They're effective in treating insomnia. The problem is that they decrease the time spent in REM cycles and in stage 3 and 4 sleep. And REM sleep is necessary to refresh and recharge from a night's sleep. So when people discontinue using these drugs, they see withdrawal rebound. You see this as soon as 2 weeks, as soon as you've used it for as little as 2 weeks or so, you'll rebound with increased insomnia, strange dreams, restlessness, waking up through the night, these types of symptoms. And it can take up to a month or so of poor sleep off the drug before a person can get back to a normal sleep cycle. The Z drugs seem to have less of a rebound effect after short-term use for most people. People experience euphoria or liking of benzodiazepines. Not everyone experiences this, but many people do. Some people report fatigue and confusion and choose not to self-administer the drug. The people who report to like benzodiazepines tend to have a history of alcohol abuse, sedative abuse, at least moderate alcohol use or opiate abuse. Um, and then one potential negative effect of these drugs is loss of anterograde memory. This is the memory of things that happened while a person was using the drug or under the influence of the drug. And this happens even at low doses. It's seen among people taking benzodiazepines for anxiety and insomnia. People on benzodiazepines also score worse on verbal memory tests. And these memory effects do not show tolerance. The problems continue. They persist months into the use of the drugs. Rohypnol, in particular, is known for inducing amnesia, which is why it's known as a date rape drug. Explicit memory is recalling specific items or facts, and then implicit memory is the ability to use that information. Explicit memory is affected by benzodiazepine use, whereas implicit memory appears not to be. The same way that alcohol grayouts, you can often trigger the memories to come back with some recall cues. That's kind of the idea here, where someone can't necessarily recall specific items or facts, but if you give them items or facts, they can use that information in an appropriate way. These drugs also cause sedation, attention deficiency, psychomotor impairment. This includes things like reaction time. With residual effects, the idea is that people use this as a sleep aid at bedtime, and the effects last into the mornings. It takes a while to shake off the effects, if you will. So someone might be impaired driving to work, or once they're at work, they might still feel the effects of the drug. And then effects on driving. This is not surprising. These drugs increase the incidence of collisions and simulations. Again, slower reaction times, impaired psychomotor abilities. It's not surprising that it has effects on driving. And then that effect is compounded if the drugs are used in conjunction with alcohol. These effects are improved with Z drugs compared with benzodiazepine, and the book mentions specifically that zolpidem can be administered even in the middle of the night with no residual effects on driving in the morning. And then people are at an especially high risk of these impairments at the early stage of taking, in the first few weeks of taking the drugs, because they're inexperienced with the drugs. So they just need to be especially aware that they might still be impaired. Like alcohol, these drugs are known to, or people using these drugs are known to be able to develop acute tolerance. So that's only specific to certain effects, though, and the book mentions a few of those. Chronic tolerance, these drugs are well known to have a chronic tolerance over time, over repeated uses. People need more and more to experience the same effects. And cross tolerance is also common among benzodiazepines and among other CNS depressants, including barbiturates and alcohol. There are two different classes of withdrawal symptoms to consider with these drugs. This is figure 7-2, and there's no y-axis here. I don't know why they didn't label the y-axis, but you can think of it as withdrawal symptoms or symptom intensity, something like that. So the tall steep curve that you see peaking at maybe 8 or 9 days, after 8 or 9 days off the drug, is called sedative hypnotic withdrawal, where a person experiences tremors, delirium, cramps, and convulsions. This type of withdrawal tends to happen with higher doses, and people need to be at those high doses for about a month or so. So it starts after just a few days off the drug, and it's pretty intense symptoms, but they're gone maybe by 14 days or so. This tends to happen with drugs that have shorter half-lives because they're eliminated so quickly through or out of the blood, out of the system. Then the low dose withdrawal syndrome you see emerging more slowly and never getting as intense. The symptoms aren't as intense as they are with the sedative hypnotic type withdrawal, but it lasts a lot longer. So these are people who are on lower doses and typically longer term, 6 months or so. So less severe symptoms, but still unpleasant. People report feeling like they're wearing a veil or walking on cotton or wool or through a mist. Some people are more, in addition, there's more symptoms listed here: anxiety, panic, irregular heartbeat, memory impairment, feelings of unreality are kind of what I was just saying with the wearing a veil. Their perception is just altered. Some people are more or less susceptible to these symptoms, and only some people go through this type of withdrawal. The estimates the book gives are somewhere between 15 to 44% of people. And then the third curve on here is symptom reemergence, where people re-experience the anxiety and the insomnia, often more intensely, but the original symptoms that they were trying to treat reemerge as well. Low dose withdrawal tends to cycle for many people. We're not sure why. And then again, I already said it tends to stick around for a lot longer time, somewhere on the order of months, or the book says even up to a year after being off the drug. And then the final point is that users of high doses for long times may have both types of withdrawal, so they're not necessarily mutually exclusive. Self-administration in humans has been studied in a couple of different laboratory studies. There was a series of choice experiments where people tended to choose placebos more than benzodiazepines. And again, this echoes what we were talking about before, where not everyone likes the effects, the fatigues, and the fatigue and the feelings of unreality. With higher doses of benzodiazepines in particular, people often preferred the placebo. And then interestingly, among people with high anxiety, they did report lowered anxiety, but still those subjects did not choose the active drug more often than the placebo. So there's a little bit of discussion in the book about how that's not a strong motivator to abuse these drugs, and people at high anxiety may not be at high risk of benzodiazepine abuse. In another set of studies, people with a history of alcohol abuse or sedative hypnotic abuse, or even just moderate drinkers, did tend to self-administer benzodiazepines more than the placebo. And there's also a task demand issue, which we talked about a couple chapters ago, where people do choose the sedatives more often if they know they will soon face a task where they need to be still or relaxed or something along those lines. In those studies, Valium was self-administered by some people, but not as often as barbiturates. And then outside the laboratory, there's a few types of problematic use. One is called iatrogenic use. This is where a doctor prescribes that the patient is getting the medication legally, but then problematic use begins, whether the prescription is extended longer than necessary or the dose is raised over time. And it's not necessarily intentional. The doctor is not necessarily trying to make people addicted. Although at times you do hear of doctors continuing a prescription for no good reason other than just to make money. And at times a patient can go doctor shopping looking for or refill their prescription early, those types of behaviors to get more of the drug than they're prescribed. But at times it's unintentional by both parties as well. And then street use is where people get a hold of these drugs illegally, and they often use them in conjunction with other drugs, typically alcohol or methadone maintenance, since these drugs increase the effect of other drugs along those lines. Animals will self-administer barbiturates, especially shorter-acting barbiturates. They'll also self-administer benzodiazepines, again, especially shorter-acting drugs. Barbiturates seem to be more reinforcing than benzodiazepines. Specifically, benzodiazepines that modulate the alpha-1 subunit of GABA-A receptors seem to be the most reinforcing of benzodiazepines. You don't need to memorize those specifics. But the drugs affecting that alpha-1 subunit seem to be the more reinforcing, and they may have a higher abuse potential among benzodiazepines. The reinforcing effects of benzodiazepines can be enhanced with priming, either with that drug or with other barbiturates or benzodiazepines. An example in the book was the rat who had the choice of chlordiazepoxide. He had a choice between that drug and water. The rats chose water, but after they were forced to have that drug, the chlordiazepoxide, then they would choose that drug. So barbiturates seem to be more powerful reinforcers initially from the beginning, but benzodiazepines can become powerful reinforcers for both humans and animals. It was originally thought that these drugs cause reproductive problems, but now there's actually reports that use of benzodiazepines actually can improve conception for couples who are having trouble conceiving. However, so it's unclear what exactly the state is with conception, but it's certainly not advised for women to take benzodiazepines during pregnancy because of the risks for the fetus. It's a teratogen in rats. These drugs are teratogens in rats, causing decreased motor activity, decreased startle reaction, and in other animals as well. They just have depressed reactions. Infants can have withdrawal symptoms if their mothers used the drugs, even just during labor, during the few hours right before they were born. Those withdrawal symptoms can include tremors, hyperactivity, irritability, and the drugs being used can also lower the newborn's APGAR score, which is a measure of how healthy a baby is, its color, its breathing, its temperature, its muscle tone, that kind of thing. So overall it's detrimental for the baby's health. Then the other major harmful effect of these drugs is overdose. Benzodiazepines are much safer than barbiturates, which is why they've mostly replaced the barbiturates. So accidental or deliberate overdose of barbiturates was fairly common before the benzos came along, but now overdose of benzodiazepines is usually not fatal. However, benzodiazepines combined with alcohol can be fatal. This mixture is at least much more often fatal than benzodiazepines alone. While overdose is not nearly as dangerous with benzodiazepines, withdrawal can be dangerous. This depends on the dose of the drugs and the length that the drugs have been used. Convulsions are an especially dangerous symptom that many people have during withdrawal. So medical supervision is recommended for people, and the way that people come off of benzodiazepines is with gradual dose reduction. They just gradually step down the dose over a period of a few months. The book says 8 to 12 weeks, but no more than 6 months. And then it's recommended that patients receive counseling to cope with anxiety and to learn alternate coping skills, both for the withdrawal symptoms as well as the initial symptoms for which the medication was prescribed.